Reminder also that AI scribes are only permitted for accessibility purposes. So if they're not previously approved by us, they might be removed, so be aware of that. I'm just looking to see if our board chair... Oh, you are fantastic.
I've joined.
Thank you. I would like to introduce you. Many of you will know Tony. For those who don't know Tony, he's the chair of CHF. He's been our chair since 2014, which is remarkable. And this will be his last Members Policy Forum as his term on our board comes to an end later this year. So I know everyone will join me in thanking Tony for his work over the last 11 years. And this is your first chance to use the React emoji. So if you go down to the bottom, there's a React emoji there. You can have a rocket, a balloon, a smiley face, a clap. Let's just try and use them because we'll be using them again during the day. So let's give Tony a thank you for all his amazing service. You can choose whatever emojis you like. Hopefully he can see some of those. And I'm now going to pass across to you, Tony. Thank you.
Thank you, Elizabeth, and apologies everyone for being late to attend. I came from another meeting of our organisation. As we start, I would like to acknowledge the Kaurna people as the traditional custodians of Adelaide, the land that I am joining the meeting from today. I wish to acknowledge and respect their continuing culture and the contribution they make to the life of the wonderful city of Adelaide and the broader Adelaide Plains region. I'd also like to acknowledge and welcome other Aboriginal and Torres Strait Islander peoples who may be attending today's meeting. Please remember to put where you are from in the chat, that'd be great. As Elizabeth indicated, it's been my privilege to be the chair of CHF since 2014. And in that time, we have seen much change, not only in our organisation, but in the broader health landscape. But two key things have not changed. The first is our commitment to ensuring that consumers are involved in all aspects of health policy, reform and service delivery, that they have a voice and that voice is sought and listened to. I must say that in all the time that I've been involved with CHF, that every opportunity I get to talk to ministers or senior people in government or in other organisations, I really stress that point. There's still some tokenism, but we've come a long way. The second key point is to work collaboratively with you, our members. So we ensure that our work reflects the diverse views of your members and that we are focusing on what is important for them. Today's forum is the 9th since we started them in 2015. We have used them to provide a number of things. One, information on areas of interest, including the importance of implementation science in helping moving ideas to action. Two, testing your views of key issues, including our previous election priorities and budget asks. And we're right in the middle of that right now, aren't we? Three, reporting back on some of CHF's research and policy work. And four, overviews of key reform developments, such as the introduction of the Wellbeing Budget Statement. This afternoon, we follow in that tradition by giving you a preview of the results of the National Consumer Sentiment Survey and inviting your thoughts on how we can improve our collaboration on policy and reforms through a member policy network. I'm sure you will find both of interest and that they will stimulate discussion now and into the future. I encourage you to participate in that discussion and look to ways that you can engage with us in the future. Back to you, Elizabeth. Thank you.
Thank you so much, Tony. We're going to start the meeting generally now, and we have two things to discuss, as you saw on the agenda there, the sentiment survey results and also the policy forum. Just before, I'd like to take a screenshot of everyone on the meeting so we can post it on our social media. So if you're comfortable, can I ask you to put your camera on if you don't have it on already, just for a moment? We love it if you leave it on the whole time, but if it's not on right now, if you just pop it on if you can for a few moments, and then we'll take a photo. Shannon, I'm relying on you to be able to manage technology.
Yes, well, if I just get everyone to jump on and hopefully this is everyone, I'll give a countdown 3, 2, 1, and everyone just gives a big smile and then I'll take the screenshot.
Thanks, Shannon.
Okay. All right, everyone's online. All right. Yep, everyone's online. Okay, 1, 2, 3. Smile, everyone. Okay, I'll pop the screenshot in the chat so that everyone can have a look.
Great. Thanks, Shannon. Fantastic. So as Tony said, today's forum is in 2 parts. There's the preview of the results we'll move to in just a moment, and then we'll talk about the policy piece. So this is the first of 4 annual surveys that we're funded for through the Strengthening Medicare initiative. And this is a survey of 5,000 respondents, 5,000. The aim was to get a picture of what people felt about the health system with a focus on primary care. It's a sentiment survey. So Jo Ruth, the Director of Policy and Research, and Lisa Smith, the Policy and Research Officer, are going to take you through the key findings. After that, we'll be asking Scott Thrift to give his thoughts, as he is working with us from a consumer perspective and chairing some of the work here as well. He's the chair of the Consumer Advisory Committee for the survey project and also sits on the steering committee. And then we'll have about 15 minutes for this discussion. So what I'm going to encourage you to do are 2 things during the presentation. The first is any questions, throw them straight in the chat. Just throw them in the chat and then we'll try and answer as many as we can. And we might even be able to answer them during the presentation. So anything comes up, throw it in. Also during the presentation, use your emojis. If you like something, if something's interesting, let us know. Something you can have the surprised face if something surprises you. The second half of the forum will be looking at this proposal about a members policy network, and we'll talk about that in a little while. And Jo and Naomi, one of our policy officers, are keen to have your thoughts on this. So if you've got a question, pop it in the chat, express your reactions, and now I'm going to hand over to Jo and Lisa. Thank you.
Thank you, Elizabeth. Lisa's going to share the slides, so I'll just get her a minute to, there we go. Yeah, thanks for the introduction, and thank you to everybody for coming along and spending an hour with us to go over these results, which, you know, it's quite exciting to do, really. These are unpublished. You're getting a sneak preview, so we're not sure just when we're going to publish, but we'll hopefully do that within the next month. So Lisa, if we can move on. As Elizabeth said, the overall aim of the survey was to improve understanding of the health system from the perspective of consumers. We focused on adults' experience of healthcare and their satisfaction with their health. So one of the first things we asked the survey fieldwork organisation to do was to ensure it was just for adults. We compare Australians' experiences of and level of satisfaction, and then we look at some of the barriers to healthcare provision. So that's it in a nutshell, really. Moving on, Lisa. As Elizabeth said, this was funded by the Department of Health and Aged Care under our Strengthening Medicare contract, which we got in the budget. It seems such a long time ago now. It's an ongoing project to deliver 4 national consumer sentiment surveys. This follows on from 2 previous national consumer sentiment surveys we did in 2018 and 2021 with Macquarie University as a partner. We used some of the questions from the previous surveys, but then we focused more on primary health and obviously went for a much bigger survey. And just for those who are interested, we used Roy Morgan for the field work. So, Lisa. So no project would be able to happen without some sort of governance and basically some steerage. So we had a steering committee. We had Scott as a consumer. There were members of the Department of Health and Aged Care from various parts of that department, and then there was CHF, and that pretty much was the steering committee. We started off with a review of other health surveys in the field. So we looked at the National Health Survey. We refreshed our view of our own sentiments, previous sentiment surveys, and we looked at things like the patient satisfaction surveys that other people have done. So we did a fairly comprehensive look at what other people had done and to try and design our questionnaire. Then in February 2024, we conducted some consultations. We invited some consumers to be part of that, and some of you on here may well have been part of it, and certainly Scott was. And Scott was the chair for the 2 consumer consultations. So he helped us run them. And I know he's going to talk a bit about the process from a consumer perspective later on. We then looked at whether there were any measures in the field that would be beneficial to add to our survey. And we looked particularly to some questions on health literacy. And we added some questions from the health literacy questionnaire about navigating the health system, because it's really not just an sort of concept of health literacy, it's whether people have the capacity to find the services that they wanted is particularly what we were interested in. So that's the background to the survey. And now I might go to Lisa, who's going to, as she did all the work, Lisa's going to talk us through the survey 1 and what we did in it and what the results are. So Lisa, over to you.
Thanks very much, Jo. And yes, now on to the 2024 survey itself. So as Elizabeth mentioned, this was the first of our planned surveys over the next 3 years. The field work took place online between October and November last year. In order for the sample to be as nationally representative as possible, the recruitment of respondents involved interlocking quotas of gender, age, and geographic region. So this was to ensure that our sample matched the broad demographics of the population. And then after data cleaning was performed by Roy Morgan Research, we had data remaining from 5,029 respondents. So overall, some of the key features of this survey is that it's nationally representative. So we can explore some of the barriers to care that Australians are facing, and also that it was developed in consultation with consumers and department staff. So as this is the first of the 4 surveys, we wanted to set a benchmark for future reporting. So we have broadly reported findings for the overall population, as well as breaking down some findings by these broad socio-demographic groups. So we looked at gender. At this time, we were only able to look at males and females. While some respondents did report that they were non-binary or that they preferred to use another term to describe their gender, we did not have sufficient sample size for these groups to conduct the between groups analysis. We also looked at age, breaking our population into 4 different age groups. We had 18 to 24, 25 to 44, 45 to 64, and then those aged over 65. We reported on whether a participant resided in a major city versus elsewhere in Australia. And to create the group consisting of people outside a major city, we combined people who lived in inner regional, outer regional, remote or very remote participants to form these 2 broad groups. We report on participants' education status and compare people who completed studies up to the end of secondary school with those who completed additional qualifications after Year 12. We also report on whether a respondent speaks a language other than English at home, whether they have private health insurance, and whether they have a chronic health condition. And now onto the results. So we asked respondents to report on whether they had accessed a range of healthcare services in person over the past year, as well as their satisfaction with these services. We provided a list of 14 different healthcare services. So for example, including GPs, nurse practitioners at a GP, dentists, pharmacies, specialists, psychologists, public or private hospitals, urgent care clinics, as well as others. The most commonly attended services were GPs, with 81% of all respondents saying that they had attended one in the past year. A pharmacist was then at 67.1%, and dental and oral health services had 49.2% of respondents saying that they had attended in the past year. When looking at how respondents rated their in-person health services, we found that of the 14 that we listed, 10 of those had over 80% of respondents stating that they were somewhat or very satisfied with their experience, which is a really great finding. Those who had attended an appointment with a nurse within a general practice were the most satisfied, with 90.1% reporting that they were either somewhat or very satisfied. Over 88% of people who had attended a pharmacy or dentist or oral health service in the past year reported being satisfied with these services. So then the services that had less satisfaction reported, these were urgent care clinics with 73% satisfied, pain clinics where 65% of people who use them were satisfied, and an Aboriginal community controlled health service or Indigenous health practitioner with 63.1% satisfied. So respondents were also asked to report on their use and satisfaction with health care that they had accessed remotely or in the home. More than 1/3, 37.8% of respondents reported having taken part in a telephone consultation with a health professional within the past 12 months, while 1 in 10 respondents had a video consultation during the past year. As some people had experienced both telephone and online consultations, this meant that overall 42.5% of respondents had received a telehealth consultation of some kind in the past year. Telephone or online support services, such as Health Direct or Lifeline, have been used by 9.3% of respondents. 1 in 20 respondents reported having received a home visit from a health professional other than a GP, while 3.8% had been visited at home by a GP. Overall satisfaction was quite high across all remote and at-home healthcare, the highest being 86.2% of people who were satisfied with their telehealth appointment, and the lowest was at 76.7% satisfied by the home visit from a GP. We then asked all respondents who had attended at least one type of either in-person or remote healthcare how satisfied they were with the quality of care they had received over the past 12 months. So overall, 81% of respondents said that they were either somewhat or very satisfied with the quality of healthcare they had received. When we investigated this for differences between demographic groups, we found that older people were more likely to report satisfaction. We had 9 out of 10 people over 65 telling us that they were satisfied with the quality of healthcare they had received. Those who were less satisfied with their care were younger adults, people residing in low SES areas, people who spoke a language other than English, and people who did not have private health insurance. There were no differences between groups across gender, area of residence, educational level, or between those who had a chronic health condition compared to those who did not. Now on to after hours care. So after hours care was defined as being after 6 p.m. on a weeknight, after 1 p.m. on a Saturday, or at any time on a Sunday or public holiday. We asked a couple of questions about after hours care. The first being whether there had been a time in the past 12 months where a respondent needed after hours medical care for themselves or a family member. We found 30% of all respondents told us that they required after hours care in some sort over the past year. We asked respondents to tell us what type of care they had accessed, and they could provide multiple responses for this. The most common source of help was an emergency department, with 59.9% of people who had accessed after hours care saying that they did so via an emergency department. And this may have been entirely appropriate. We did not ask why people needed after hours care. And then phone advice lines like Health Direct, that was also very popular, with 19.5% of people saying they accessed care in this way. We did find a small percentage, 7.2%, who said that they needed after hours help but they did not access support. And we didn't ask any further questions on this, so we don't know the reasons why these people did not access the required care. We also asked all respondents how easy they thought it would be to access after-hours care without going to an emergency department. 45.8% stated it would be difficult or very difficult, and only 1 in 5 said it would be easy or somewhat easy. The groups who are less likely to report that access to after-hours care would be easy were females, older adults, particularly those aged over 65 years, and not surprisingly, people outside of major cities, people residing in low and mid SES areas, and also people without private health insurance. We then asked respondents about My Medicare, the voluntary patient registration system that was launched a year prior to the survey taking place. My Medicare aims to formalise relationships with the GP and other primary care professionals with some expected benefits to continuity of care, longer telehealth appointments, and better care planning for people in aged care. So at the time of the survey and 1 year after My Medicare's launch, 1/3 of Medicare cardholders had heard of My Medicare. Findings suggest that overall 17% of Medicare holders had registered for My Medicare. And then amongst those who had heard of My Medicare, 16.1% were undecided about whether to register, wanting more information before they registered. We also captured the reasons for registering, and the most common reason was to improve how healthcare providers work together to meet healthcare needs. The second most common reason was because the GP had suggested it, and then 31% of people said that it was to access the benefits through My Medicare. Next, we asked about My Health Record. So a 2019 audit showed that 90% of Australians have a My Health Record. So perhaps it's a little bit concerning that only 70% of our respondents had heard of My Health Record. Young people were less likely to be aware of My Health Record. Less than half of 18 to 24-year-olds we surveyed had heard of My Health Record. Males were also less likely to be aware of My Health Record compared to females. People who had completed education up to the end of secondary school were less likely to be aware of My Health Record compared to those who had completed further studies. Additionally, people who spoke a language other than English and those without a chronic condition were also less likely to have heard of My Health Record. Amongst the respondents who had heard of My Health Record, 36.9% reported that they had ever used it. When looking at this value as a percentage of the whole survey population, this was the equivalent of around 1 in 4 or 26% of all Australian adults ever having used their My Health Record. Those who had reported using their My Health Record were mostly positive about their experiences. So they were highly likely to agree that it makes it easier to access and share their health information, and that it stores all of the important information about their health. Then we looked at some of the potential barriers to care that people may be facing. We asked respondents, was there a time in the past year when you needed help but you were unable to do the following? And we had these 4 options listed here of filling a prescription, speaking to a doctor, taking up a recommended test, treatment or appointment, or visiting a dentist. So almost half of all respondents told us that there had been a time, at least one time during the past year, when they did not get the healthcare that they needed. We asked a range of subsequent questions with possible reasons for having missed these services. A range of explanations were given for having unmet health needs, including timing, personal reasons such as being too busy, ongoing concerns about COVID transmission, and feelings of shame and stigma. When thinking back over the past year, affordability was cited as the most common factor for people having not filled a prescription for medicine, taking a medical test, treatment, or attending an appointment that had been recommended, or visiting a dentist when needed. These findings suggest that overall 7.7% of Australians had been unable to fill a prescription, take medicine when needed due to cost on at least one occasion in the past year. Meanwhile, 8.7% of respondents reported there had been a time during the past year when cost prevented them from speaking to a doctor when needed. Almost 1 in 10 had at some point during the past year not taken up a recommended test, treatment, or attended an appointment due to cost. And almost 1 in 5, at 19%, stated that there had been a time during the past year when they had not visited a dentist due to cost. So looking at all care types together, this then led to 1 in 4 Australians who stated that cost had been among the reasons for not accessing the care that they needed during the past year. We then grouped together all participants who had indicated they had not been able to access at least one of these 4 services and explored whether there are any major differences reported by demographic groups. So the population groups who were significantly more likely to say that there had been an occasion where they had not accessed the healthcare they needed were females, adults aged under 45 years, people living in low or mid SES areas compared to those in high SES areas, individuals without private health insurance, and people living with a chronic health condition. Okay, and then we wanted to look at how respondents understand the healthcare system. Health navigation was a topic that had been raised by consumers in workshops a year ago. So we looked to include the health navigation scale on the health literacy questionnaire. Lower scores on the health navigation scale indicate that individuals will, on average, face greater difficulties identifying and accessing the support they need. So in practice, this might mean that an individual has greater difficulty in advocating for themselves, in finding people to help address their health needs, or that they have limited knowledge of what resources and support they are entitled to. So we had an average score from our study of 3.5 on this domain, which is good, but it's important to note that back in 2018 on the National Health Literacy Survey, the average score for Australian adults was 4.0. So this is definitely an area that we'll be looking at over future surveys. We haven't used this measure consistently, so definitely something to watch. The survey also identified groups with significantly lower scores. These were younger adults, people residing in low SES areas, people without private health insurance, and people with a chronic health condition. So despite this, most people told us that they are capable to work with health professionals to reach decisions, with 70% saying that they felt included in decisions about their health. 3 out of 4 people said that their healthcare providers make sure they understand the information that they are provided. 74% said that they're happy with the way they receive health information. And conversely, 1 in 4 respondents reported feeling rushed during healthcare appointments. So then we looked at discrimination and disrespect. Overall, 8.1% of respondents who had accessed care in the past 12 months reported that they had experienced discrimination or disrespect during their healthcare service. When examining responses by demographic groups, this highlighted several groups who were significantly more likely to report having experienced discrimination or disrespect in the past year. So it was females, people aged 25 to 44, respondents residing in low SES areas, people without private health insurance, and adults with a chronic health condition. We then asked respondents about their overall confidence in the healthcare system over the past year. 62.3% reported that their confidence had stayed the same, while only 6.4% reported that their confidence had increased over the past year. Concerningly, around 1 in 4 Australians, or 28.1%, perceived that their confidence in the Australian healthcare system had decreased over this time. Of those who said it decreased, we then looked further for any differences between the demographic groups. The population groups who were most likely to report their confidence had decreased in the past year were females, with roughly a third reporting that their confidence in the healthcare system had declined in the past year, compared to only 1 in 5 males. Adults living in both low and mid SES areas compared to adults in high SES areas. People living with chronic health conditions compared to those without chronic health conditions, and people without private health insurance compared to those with private health insurance. Okay. We then also asked participants to select a statement that came closest to expressing their overall view of the healthcare system in Australia. Around half of respondents said that there are some good things about our healthcare in Australia, but major changes are needed to make it work better. And then approximately a third said it usually works pretty well and only minor changes are needed. And then 7.2% said healthcare in Australia has so much wrong with it that we need to completely rebuild it. And then 3.1% said that none of those statements had reflected their views. We also asked for respondents' thoughts on government spending in healthcare. More than half of respondents felt that spending was too low, and 1/4 said that it was about the right amount. A small minority believed that government spending on healthcare was too high, and a further 15.7% responded that they did not know. Finally, we asked respondents what were the most urgent areas of the healthcare system that needed improvement. And participants called for the following areas to be most urgently improved. And that was to have more doctors, nurses, and other healthcare workers. And 39.4% of people said this. Then 22% of people said to improve the cost of care and medicines. And then 8.4% said better access to care. And now on to discussing some of the limitations of the study. So the survey was administered online and in English, and this excluded individuals who are unable to complete the survey in this format. Therefore, survey estimates relating to barriers of care are likely to be conservative, as people with no or limited access to digital technologies or with low levels of English proficiency may face additional barriers to care. Then the sample was drawn from a panel, and whilst quota sampling was applied to match the profile of respondents to the general population, there is some evidence to show that the characteristics of people that join panels may be different from people in the general population, and some of these biases may not be corrected by weighting. And then under the ethics approval, we are not able to conduct specific analysis of the results from First Nations people. To have such analysis approved by the Ethics Committee, we're required to conduct further consultations with First Nations people and communities, and to undergo a separate ethics process. So further analysis on First Nations people may be something that we'd like to explore in later iterations of the survey, but at this time we can't report any specific results relating to First Nations people. So now I will hand back over to Jo to discuss our current work and our next steps going forward. Thanks, Jo.
Thank you so much, Lisa. And I know there's a lot there for everybody to get your heads around. And I have tried to answer some of the questions in the chat. And thank you to Lisa for going through all of that. I don't think there's any real surprises there. Sometimes it's good to have what you think you know confirmed, if nothing else. So, I don't think there was anything there that we sort of went, oh, really? But we'll see if future surveys tell us anything different. Where we're up to is the report that Lisa's just taken you through has been submitted to the Department of Health and Aged Care for review, and we're making final changes to the report, and then we'll be looking to publish in the coming months. This will be published as a CHF report, not a government report, just a distinction. Wave 2, the second survey, was collected between 24th of February and 25th of March. That was really good. We were a bit concerned that it might take us longer to get to the sample size, but we were happy to see that it didn't. And we're about to get the data, and Lisa's looking forward to that because Lisa really likes the data part. So it's good that she's here. And then we'll begin our analysis of the next wave soon with an aim of getting preliminary results by the end of the financial year, so the end of June. Then we go on to planning for waves 3 and 4. And between July and September, we'll be looking to get feedback from consumers and the department on the results from the first 2 waves to inform what the questions might look like in waves 3 and 4. We may decide to change some questions. One of the things that has come up a lot is that we didn't really explore why people said what they said. So, and for a broad survey like this, that would be hard. We want to keep it to 15 minutes. We don't want to have a lot of open text for this kind of survey. But maybe if not through this survey, there are some areas there where there may be room for some further work by us or by others to find out why people say that. What if they couldn't access after hours care, why not? What did they go to after hours care for the first thing, and then what was the problem that they encountered? And so I think we would like to have a look at some of those things perhaps in the future, and then we'll be going for new ethics approval probably by September this year, because as some of us know, it takes ages to get an ethics approval and it's a lot of work. And very time consuming. Okay, Lisa, and I think that takes us to the end of what we were going to say. So it's now over. Thank you, Lisa. So it's now over to you, Elizabeth, and to Scott.
Great, thank you. And thanks, Jo, for answering some of those questions in the chat. I'm sure people have more questions. I'd love you to pop them in the chat, because I'm going to ask Scott to give his insights about being involved in the experience. Then we will have time for some questions, so pop them in and we'll get on to those. So Scott, can I introduce you now and encourage you to provide us with your thoughts about the process?
Thanks for that, Elizabeth, and good afternoon, everyone. So my name's Scott, and I have been very lucky to have been able to participate in this process. It's been very interesting from a consumer perspective to be involved in a steering committee at a federal level. It certainly opened my eyes to the machinations of federal politics and the way these things work. So brief background. So moving considerable amount of time ago now, I was asked to chair 2 consumer meetings to look at a brief of questions and to see what everyone wanted to find out from this survey. We had a very broad range of participants in those 2 surveys. We had people from the city, we had people from the bush, we had one lady sitting on the stoop of a rundown, disused, shed up on a hill because it's the only place she could get signal on her phone. We had elderly people, we had young people. So it was, I think we had a very good representation for 2 small groups. And a lot of their questions certainly went into the survey questions for wave 1 and 2. And a lot of the things people were asking about was access to digital health, access to health services for people in rural and remote Australia. And I did notice a great question from Claire in the chat about pointing out that remote access can also include people who are homebound. You're living in the middle of the city of Sydney or Melbourne, but if you can't access a doctor, you're no better off than somebody out in the middle of the Nullarbor Plain. So we had those 2 great surveys, and then I was able to sit back and participate and watch and see what the departmental view of the questions was. And there was a surprising amount of alignment between what the department, DOHAC, wants to know about consumers' sentiment and what people want to know. They were also interested from a much more fiscal point of view, I think, about how people use services, what services we're going to need moving forward, what services people know about, certainly around the strengthening Medicare regime, and in the first survey, because it was a new thing, the moving into the My Medicare stream, which I'm very surprised personally by the answers in the survey. Which I'll get into that in a minute, quite things that have surprised me as a consumer. Because in our consumer surveys, everyone seemed to know about My Medicare, but I think that speaks probably to people who are participating in a CHF working group or a CHF roundtable are certainly more engaged in their healthcare already than Joe or Jane Bloggs, who is doing the survey as a randomised participant who's been brought forward through the Roy Morgan selection process. So speaking of some of the interesting things that I've seen as a consumer in these facts, I found the dissatisfaction level of people from the Indigenous background very interesting. And hopefully we'll be able, I realise that we can't, without a extensive ethics approval, look at that in a future survey, but it certainly that stood out. And also the amount of people, or the lack of people now accessing electronic health, be it video conferencing. And I know that hopefully, fingers crossed, we will be able to run a couple more consumer panels before the next wave of surveys, and hopefully within the 15-minute time frame and within the information that DOHAC in under whatever government and whatever format that will look like after next month is looking at, is to finding out why people have fallen away from using electronic health. You know, is it because of changes in policy, changes in funding, changes in cost? And I also found it very interesting that there seems to be, you know, a lot of our young adults who've participated in the survey are dissatisfied with their health or with the services provided, but also that the younger people are less engaged in their health according to the question, you know, the responses to this questionnaire. And it certainly raises for me the question of whether these sort of questionnaires get a lot more honest responses, because unlike a survey that would be run, for instance, by an Aboriginal health service or by a youth health service, where there's a strong likelihood that the participants will be known to each other, they'll be known to the surveyors. This sort of survey through using a company like Roy Morgan is very, very, I can't say this word, anonymous. And so you do get, I think you get a much more truthful response from people. You know, people are much more likely to say, I don't know, I don't understand, or I don't agree, when you don't have to walk into the clinic the next morning and see the person you've just disagreed with. I think there's certainly some interesting questions to be asked going forward about after hours care. I'm very fortunate myself to live in the outer suburbs of Sydney, but to have a wonderful after hours clinic just down the road from me. Whereas I know that my parents, who live up in the middle of northern New South Wales and New England, their idea of after hours care is an hour's drive somewhere and hoping for the best. So again, some great responses and some very interesting responses from people, and hopefully some very useful information for the department moving forward. And again, for whatever form our next government takes, as to the building and the inclusion of an expansion of after hours care and all the wonderful things we would like to see around things like dental care and mental health care being part of that. And hopefully they're things that through these surveys, DOHAC will be able to see. And I must say that especially in the last number of meetings, one of the things I have learned is the tribulations that CHF goes through when trying to deal with government departments, because every time you go to a meeting, you have 6 faces, you don't know any of them, they don't know who was at the last meeting. Whereas now, because there's data being given out by CHF to DOHAC, it's all of a sudden we've got these wonderful people in who are the statisticians and the deep thinkers within the department who never change, despite who is the minister or the prime minister or the talking head. And they're the people who actually make the difference, and they ask wonderfully involved questions. And I like to feel that the questions I've been able to ask, and I think it's been a surprise for the people from DOHAC to have a consumer member sitting in on their meetings and asking questions and raising my hand and saying, well, hang on, have you thought of this? It's more than, it's a set of figures, but it's a set of figures representing people and representing people's opinions. And I, within these meetings, I quite often notice someone will, a little ooh in the background, and it'll spark a question from a statistician or a departmental figure who says, well, we didn't think of that, but now we will go away and think of that. And I hope that the presence of a consumer there does say to government at high level that, well, we need to have these people in our conversations too. We need to listen, and we need to ask CHF or the state-based organisations, a lot of whom I can see represented in this meeting today, to reach out and say, give us your consumers. And that's me. Thank you for listening.
Thanks so much, Scott. Really great to get your insights and hear from a consumer who's on the ground with our work and how it went, and your newfound knowledge about working with the department. Welcome to the club. So we've got some time for questions now, and I see there's a question in the chat that you've asked, Claire. So you can, everyone can ask their own questions themselves. So if you're happy to speak your question, Claire, I think it's the last one you've asked about you're asking us what the department's plans are about seeking views. Happy for you to paraphrase that, and then Joe and I can probably give response noting we are not the department. Would you like to ask that one?
Yeah, thank you. I think because here in Western Australia, I guess we see the day-to-day reality of people from these groups that do experience discrimination at, quite eye-watering levels. And I guess to ask the question about the experience of discrimination, but then not be able to draw out the experiences of the groups that I think would be likely to be reporting much higher levels of discrimination. I guess I see a risk, which is this data will be used to identify responses to discrimination without having captured being able to draw out anyway the experiences of the groups that often do experience it. So I'm not exactly paraphrasing, I'm probably expanding on. And I guess the reason for me asking about DOHAC's views was I imagine that you might have already made these points to the department. And so I guess I'm just curious, because again, I'm very happy for us to lobby from here as a member of CHF and as the state peak to say that if you're going to be investing in this level of grassroots community feedback, that how else can we help advocate for that being a more comprehensive set of feedback? Thanks.
Joe, do you want to respond about any conversations you might have had with the department in relation to this?
Yeah, sure. I mean, I think what I would say, Claire, is that this survey and that particular set of questions does lend itself to doing more work. I think we need to, just the fact that even the broad data that we've got there shows that there's a problem that needs to be addressed. But I think it needs to be done as separate work. So I think you would not lump those groups all together and do a piece of work. You'd have to go to each cohort. So you'd have to go to First Nations people. You'd have to go to multicultural consumers. So, you know, we will take the results to somebody like the Australian Multicultural Health Collaborative and say to them, this is what it said. Is there scope to do any extra work? At the moment, there's no formal plans, but for each of those groups that you've listed there, the department does do a lot of work with those, and may well do some research and may fund us to do some more work on this, because we're having discussions about further surveys, or might go to the groups that actually whose bread and butter is representing those groups, whose membership is those groups. I would not take it upon myself to speak for First Nations. I'm not a First Nations person. CHF does not have those. So I think we would be saying, take this, go away, talk to each of those groups and do an appropriate consultation with them about discrimination and, and disadvantage and that way. So I think that's what we would see this as a contribution to get a conversation going.
I think the only thing I'd offer in that space is that those members are your members, like they're members of our grassroots organisations, and they are consumers in Australia. And so I guess for me, the slight challenge is that if at any point the government is using this data as this is the experience of health consumers, and I think for me, one of the potential challenges is that when we do say, oh, you know what, this has probably captured the experience of like 80% of the population, the groups that are always underrepresented in those conversations are those groups that experience the deeper inequities. So I'll finish there. Thank you. Thanks, Jo. And I do appreciate the challenge.
Great. Thank you. Keith, you've got your hand up. You've got a question?
You're on mute. Keith.
Thanks. Sorry. Keith, Health Consumers Queensland. Thanks very much, Jo and Lisa and Elizabeth and everybody else, Scott. I'd like to highlight firstly two things that we are seeing and hearing have really come out in your data. And so picking up on what you said, Jo, it's nice to have things confirmed. And that's, I'm going to use the old-fashioned words, poverty and discrimination. And what we're seeing and hearing is not only in primary care are people struggling to afford the primary care services in their communities, but that's then flowing on to not only more presentations to emergency department, but more choices not to go to another service. That's come up in particularly for people with chronic health conditions, First Nations, and people in areas of low socioeconomic advantage. And we are starting to see people choose not to access things like perinatal care, which is obviously horrific for the health of mums and bubs. So what I'd be really interested in asking, if you have the capacity to do more work, is are people choosing not to access care, and can that be used to inform the evidence base going back to the Department of Health and Aged Care so that they can understand the flow through implications of people into the rest of the health systems?
Thanks, Keith. Jo, you might like to respond.
Yes, is the answer. Short answer, Keith. We did ask the question about if people hadn't accessed care or had difficulty accessing care, but we didn't, and cost was a quarter of them. So I think there is more work to be done about what barriers. I mean, Elizabeth could talk to this, but sometimes cost isn't the primary reason. Sometimes actually accessing the service is the primary reason, and people have a sort of, if you like, a hierarchy of need, to not the one that most of us would quote at, but have a hierarchy. And it's the first thing is the service there, and is it actually accessible by them? So it can be there, but they can't get at it for a variety of reasons. And then like it's 200 kilometers away, or it's not open at the time they need it. And sometimes cost is sort of third or fourth down the rung, And, you know, sometimes quality comes into it and people will go, any service is better than no service. And, you know, rural people will often tell you that. And so I think it's really complicated. And I think that's something that actually why people don't go and get care is something that we all need to explore more. I think, and I'm not sure that waves 3 and 4, we might, depending on the government of the day, and we'll know that sooner rather than later, might want to steer away the 3rd and 4th survey in particular direction, because this was the current government's agenda, which addressed some of Claire's comments. They wanted us to ask about primary care. Strengthening Medicare was predominantly about primary care. We know hospitals are part of Medicare, but it was primarily the primary care part. And primary care is most people's interaction with the health system is through the primary care system. So we wanted to, so yes, I think there does need to be more work done around poverty and affordability and quite what that means, and, you know, people missing important components of care.
Thanks, Jo. I might just add, we go around the country talking to places. We've been in Tassie for a few days. We had the privilege of being last year for a little while in Western Australia and in the eastern seaboard a bit. One of the things that I think you can see when you talk to consumers and our other member organisations is that if you're in a highly urbanised area, like you're in Perth or you're in Parramatta, cost seems to be the first thing that you hit. I can't afford it. So there might be a service, and the first thing you realise you can't do is you can't afford it. As soon as you step out of that into a remote area, whether that's in Tasmania or that's in the Pilbara, then it is about actually, is there one? That accessibility is the first thing. Is there one? And then if there is one, as Jo said, then could I get there? Would it work for me? Is there even a safe model of care? And then if those things are all true, then it's like, how would I afford to do this anyway? So it seems to me that for people, that access and affordability were important, that depending on where you live, there's a little bit of a shift in which order you might do those. So in Queensland, for example, Keith, it'd be fascinating to know if that was different in Brisbane to what it might be in Mount Isa. You know, because if there's no gastroenterologist, then you don't even think about the cost, because the truth is, you know, you can't get a service. You don't even go down the how would I get there, because it's not a service you can access. And I think the other thing, and, you know, we'll be talking to the government about the incoming government, people can see government trying to do something about affordability. It'll take time. There are some benefits already, but there's a lot more to be done. What they can't really see is it doing anything about access. And if access is the issue, particularly for remote and rural communities, and for people who live in the middle of town but can't get out of home because they have someone with special needs, because they're bedridden, because there's no close public transport, that is equally important. So I think that's an important message. I mean, affordability seems to be everywhere, but I think it's a little more complex. Affordability or access, I think it shifts depending on the person's circumstances.
Yeah,
now we've got. Yeah, thanks, Keith. We've got time for one more question if anyone's got a question, or else we're going to move on to the second part of our session. Just looking for any hands. Got any questions?
No hands.
So can I ask you to all put your hands together in a virtual way to thank both doing an immense amount of work and some of the rest of our policy team too. 5,000 survey responses is a lot, and now we've got another 5. It's 10,000. Not long we'll have 20,000. It's a lot. And there is it's generative work, right? There'll be lots more we can do with this. Of course, being funded by the government, then it depends on what the government might like to fund us to do. So we're going to move now to the next section, which is the Members Policy Network, which is an idea we've been kicking around for a while. And we thought we might use this group as a bit of a sounding board to see if people think it might be worthwhile. So I'm going to pass across now to Jo and Naomi to talk about this idea and get people's sense of whether they think it would be of value to their organisation. Thanks, Jo.
Thank you, Elizabeth. And Naomi is on the call, is on the line, but she's nominated me. So Naomi, could you put the slides up for me? Thanks. Nope. yes, there we go. Presentation. There we go. This is just really a concept that we're wanting to get your views on, get your take on, and to see whether we should pursue this as an idea or not. So this is not something that is well thought. We're not bringing you a done deal or anything like that. This is a genuine attempt to see whether you think this is worth doing. I guess this actually came out of a discussion Naomi and I had about, Naomi's only been with us since July last year, but has done consumer engagement in the disability and mental health sphere before. And, you know, she was saying she'd like to get a better feel for what our members' policy issues are, and to be able to find out who she could talk to. So, you know, when there's a government inquiry into diabetes, as there was, who do we go and talk to? Who do we go and talk to if there's something like on rare cancers, rare voices, or if there's a funding proposal, who do we come and talk to? So we're keen to make sure that CHF policy and advocacy work represents our members' expertise and experiences. You know, we found when we were looking at our election priorities last year that we didn't have a good feel for what your priorities are and what you might be working on for election stuff, and so that we could not duplicate, we could collaborate, we could see where we have common interest and advocate together. So we wanted to make sure of that. We're looking for an opportunity for members to provide direct input into CHF's policy positions, so we can have a talk about what they are, and also for you to tell us what you're doing. So, you know, I know that some of you, I'm thinking of, we did a good collaboration with health consumers of the ACT around the recent Senate inquiry into ADHD. And we were called we each put our own submissions in, and then we were both called as witnesses, and we were put together as the witnesses at the same time. So we had a meeting and we had a look at each other's submissions, and we decided what they decided what they wanted to emphasize. We decided what we did, and it actually went really well. And I think the consumer voice was certainly not necessarily united, but was playing to its strengths and not duplicating things. So we were able to get twice as much over in the time rather than both saying the same thing. So we'd like to have a mechanism for doing that. We'd like to just have an informal mechanism to keep each other updated on key policy related activities, events and issues. So that's what we were wanting to, these are the things we want to do. If we can have the next slide, Naomi, please. No.
Sorry, I'm having some issues with my computer. 1 second.
It doesn't want to move. That's all right. You know me, I can talk through wet cement. So there we go, almost. There we go. What we're thinking of as an idea is an informal network, basically open to attendance by one policy-focused staff member or a volunteer, if that's your good, for all CHF full and associate members. So this is for our organisational members, probably not for individuals. We're looking at a different mechanism to get the views of more consumers into our work. With the potential to expand the membership in the future outside of our members, if that's what people wanted. We would undertake the sort of secretariat duties, and either we would chair or we would have a rotating chair, and then we'd have them online and we'd have them quarterly. And the idea would be that you come along if you can, we set the dates, you come, anybody could put anything on the agenda. It wouldn't be us driving the agenda necessarily. It would be open to what people wanted to talk to, you know, as we God forbid, if we have to have another budget this year for some reason, you know, we might want to kick off with that as a starter. We just hope that doesn't happen. But certainly before the end of the year, we might want to have a talk about what we would all think should go into the federal budget for next year. So I guess I love CHF will take the secretarial work. Yes, well, we all love it too. Thank you. And so that's really what we do. And so I guess we're thinking that if there is, if people think there is, and I think we've got a poll, haven't we, Shannon? Can you put the Slido up? There we go. So what we'd just like to get is if we were to establish a members policy network, would you be likely to participate? It's quite simple, yes or no. It's not a commitment. We're not going to chase you afterwards and say, you said you were going to. But if you just think it might be an idea that you think is worth taking a closer look at and you'd be happy to participate in at least doing that, then if you want to say yes or no to that, that would be good. So everybody gets a vote. Except me, I shouldn't vote. So we'll just give that a minute to come back. Depending on, let me know when you can give me the results, Shannon, just flick them up. What we were thinking was, and then we'd have an initial meeting to discuss the approach. We'd look at sort of some terms of reference because we do need to say what's in and out of the thing. And then we'd start work. This is not part of our, oh, there we go. Everybody thinks it's a good idea. There we are.
Only one person voted though, Jo.
Oh, okay.
No, sorry, I'm joking.
No, that's fine. Was it you, Elizabeth? So it wasn't me. So given that, what we'll do is in the next couple of weeks, and then Naomi's going to get a bit pale about that, but certainly maybe after Easter and Anzac Day and after the federal election, let's put it like that, we'll send out something with a date and a time. And I know that's not terribly democratic, but I think if I try to get into a doodle poll, I'm going to get nowhere. So I will send out a date and time and encourage people to come, and we'll set it, and we'll set a time and date, and we'll just have a rough sort of idea of what you want to do. And we could have a meeting like this where everybody sort of comes at what we think are the key steps, or what we might want to, what the approach looks like, and we'll take it from there. Naomi, did you want to add anything, seeing as I've just rabbited on?
Thanks, Jo. No, I think you've covered it really well. I think we just see great potential benefit there, not only for the work we're doing, but for collaboration between all the members themselves as well. And, you know, some of these sorts of policy networks exist in other sectors like ACOS, for example, and I think they can be really beneficial. So it's exciting to see that so many people are interested, and yeah, look forward to the next steps.
Okay, thank you. So I'm happy if anybody would like to make any comments, just put your hand up put your virtual hand up, and Elizabeth will field them. They're stunned. No hands up. I think everyone's in general agreement that this could be a good thing. Yep. So then, thanks, Jo. If there aren't any, did I miss something? No, just a thumbs up from Claire. Thanks, Claire. So, so the next steps, as Jo said, is that we will go out to all of our members. So some of them here today, but others not. And so we're going to put this up, and it'll be an iterative process, right? So together over a period of months, we'll work out how it works, what it can and can't do. And we do think it will be, you know, incredibly helpful. We always find it really valuable to talk to our members, and hopefully people talking amongst themselves will be equally valuable. Great, thanks, Marianne. I think that's one of the things we thought, Marianne. Some people, they are
the only person in their organisation doing policy, or that's only part of their job, and actually connecting with 10, 20, 30 people who do that all the time, just make you feel as much as anything that you're part of a community, which is really important for your work. So Naomi's email address is in the chat. For anyone who wants to share any early ideas with her, you're really welcome to contact her directly via her email. So I'm going to start to draw us to it now, and say that we really encourage you to keep in touch. Many of you already have our details, but they're there. To keep in touch on social media as well. We have a newsletter which goes out to thousands of people and has a lot of great opportunities for consumers to undertake all kinds of activities, from paid work on national committees through to surveys and the like. So we always encourage people to subscribe to that as well. I'd really like to once again give a thank you to everyone, to our chair, Tony Lawson, to Joe, Naomi, Shannon behind the scenes, and Lisa for their presentations today. And really thank you for spending your valuable time with us. And we stay tuned, and we'll come up with more details about the survey over the coming months. We'll leave the meeting open for a minute or two. We always love your feedback. Anything you'd like us to do next time differently, things that we didn't mention that you wouldn't mind finding out about, pop your questions in the chat and we'll find someone who can answer that and get back to you. Otherwise, we'll hope you have a great rest of your Thursday, folks.
Thank you.